So, hello everybody. I'll say hello again. So I'm Gary Stobie. As I mentioned at the beginning, I'm a clinical professor at the University of Washington. My colleague Katrina Davis, who I've worked with over the years at Seattle Children's Hospital in Seattle and also at the University of Washington. Um, we are older in our life pattern. Which means we have a lot of experience, both of us, both Katrina with her own family, and then me with a lot of families over the years. I am an adult neurologist, and so I'm actually rare in this field, and I really got interested in this topic that we're going to talk about now, which is transition to adulthood. So let's go to the next slide. Um, so what we're going to try to do today is we're going to talk about what we know about kind of outcome trajectories. I guarantee you, this is like one of the questions on every parent's mind when an autism diagnosis is made is like, what's the outcome look like, for my child? We're going to recognize some of the barriers that can impact us, and we'll highlighting some of the medical and mental health things like we've highlighted in the case. And then we're going to look at like living as an adult and like strategies for improving quality of life going forward. And I like that. I like that top thinking about quality of life. I feel like that spans across the spectrum of outcomes, that our goal is quality of life. I'm going to go to the next slide. I want reminding us again. You'll hear me probably use both person first and identity first language. I am steeped in the medical model. So I was raised using person first, a person with autism. In part due to the failure of our system at training our medical providers, I've been trained by my families and my patients. So my language has changed over the years, and I use more identity first language than I used to 20 years ago. Katrina, um,
Mm-hmm.
I know that you as a family member and as a family advocate, um, you've at times been frustrated by the push and pull between uh, self advocates and family advocates, and there's a lot of things that are common, but there are things that are also sometimes butt heads. Um, and I know that we're going to try to do our best to be balanced. I don't know if you want to add anything to that.
I'll just say one thing, folks, is that Gary's right that sometimes I'm not frustrated at so much self advocates, but this big giant ball that is autism, this beautiful thing. When we talk about autism as identity, and maybe I might hear identity only, it's not a disability. And we all know, well, I know that autism can also be a profound disability for some. And I think when we go to extremes, that we run the risk of sugarcoating difficult realities when we overlook or ignore or don't recognize significant challenging behaviors, profound intellectual impairment, low adaptive skills, all these things that I call profound autism. Some autistic people are profoundly autistic, and so I think my son autism has always been his identity. I don't want to cure or fix him, but for him, it's also a profound disability requiring much different supports and services than someone who doesn't have profound autism. So one size doesn't fit all. We have to be sensitive how we talk about autism, and most important, we have to involve parents of that population. Thanks.
Thank you, Katrina. So I'm going to do a couple slides just to get us framed with a little bit of background as we kind of try to reach for our objectives. I will say I have art scattered through my presentation. This is art by Andrew Mito, who I use his cards around the holidays. So thanks, Andy. Next slide, please. Um, we continue to strive to perfectly define this nebulous thing we call autism that has challenged us, and it's changed over the years with regards to definition. We're currently working on this DSM-5 version, which has introduced kind of severity and qualifiers into this what is being what is being lumped as autism spectrum disorders. Um, what I observe with this, I notice is it's a tendency to swing between the lumpers and the splitters. and you'll get one version that'll be trying to combine everything, and then the next version tries to split it, and then the next version tries to lump it. And so this last one tried to lump it, so probably DSM-6 will try to split it again. My point of highlighting this slide, though, is when you look at trajectory and outcomes as adults, you have to be very cautious when you interpret data that's published, because if you're looking at publishing data on 50-year-olds right now, those 50-year-olds did not use DSM-5 to get to their diagnosis. So always a question of does the research represent what we see as autism now? So it's a good kind of framework. So next slide. Um, what I can say, regardless of these diagnostic criteria, um, we all should care about this, because we're at the point where now approximately 3% of 8-year-olds meet criteria for autism spectrum disorder in the United States, according to our CDC data. So this has become a big deal. This is not just in the U.S. This is globally, which means there's a lot of people becoming and living with autism as adults. If you go to our next slide. So let's think about these outcomes. If you go to the next slide, I made this. I used some research from a number of years ago, and I still like to use this slide. I think that I will say that these do not get hung up on the exact numbers of these outcomes, but let me just define a few things. So um, when I'm talking to families, I kind of think about it as three groups. I think about this one group that was defined in research literature as quote unquote optimal outcome group. And this is an 18-year-old, when you're talking to them on the surface, if it was an unexperienced person, they wouldn't necessarily say this person has autism. This is somebody that's going to go on and be independent, have a job, um, but probably needed some supports in their schooling and their post. Often likely has some anxiety and depression going on too. So this optimal outcome group is implying that they are able to function independently in the community as an adult. There's a flip side of that, which is this group that I say needs 24/7 support. And those are individuals, like AC, that need eyes on, and help in daily activity, both in home and community. And then the biggest group is really the middle group, which needs supports into adulthood, but continues to make progress. And ideally, those supports can kind of retract as the person has more agency and capabilities on their own. DSM-5 tried to do this with leveling based on supports. And they purposely did this when the committee that did DSM-5, they purposely did not call this severity. Yet people interpret it that way, which is understandable. And it's very vague, requiring supports, requiring substantial supports, requiring very substantial supports. And DSM-5 goes into description of this. And I'm fine with it being vague, because quite frankly, it's really hard to do it. I as a provider, I like this, because I can communicate with another provider and I could say it's a autism spectrum disorder, with or without intellectual disability, with or without language impairment, level 2. That tells a lot in just that one sentence. Okay. The trouble is, if you met that person at 6 p.m., they may be a different level than at 8 a.m. If you met them in December, they may have different than in November. And if you met them at age 25, I guarantee you they're different than they were at age 15. So this is it's defined as very static, but we all know it's not static. Let's go to the next slide. So another thing, and this is probably a point that really got me excited into this field and why now I only do neurodevelopmental work as a neurologist, is it just so happened I lucked out in Seattle. I was like the only adult provider that seemed to be interested in the population. So I had a lot of patients coming my way in their 20s, and I was seeing kids that were making kids that were now adults making progress in their 20s. And I made this slide and I still use it. And what this is talking about is it's kind of these different phases. This phase and the steady line that is called DD, that you can think of that as autism with somebody with a developmental disorder, and then the so-called typical quote unquote development. And we're specifically talking about developmental progression with social communication. Okay. So typically developing humans, when you look at their primary school years and middle school years, their social communication is just going out out the roof. I mean, amazing progress, right? A person with autism and developmental disability is making progress compared to themselves a few years ago. But when you compare them to their peers, they're probably still falling further behind during that phase, right? Then their typical peers start to plateau. They're getting into young adulthood. They start to plateau. Our folks with autism and developmental disorders continue to make progress. And so that has been really rewarding for me and for families when they come back and tell me, hey, you were right. Wow, we're doing way better than we were before. Um, Not so easy, and there's challenges. If you go to the next slide, AC, Katrina's son, was an example of this other thing that we see. And the research has shown that this number, this so-called poor transition, which could be due to loss of services, mental health issues, all these things we talked about, is upwards of 20% that go through this. So this is common. And as medical providers, this is often the group we're dealing with in that age, kind of 16 to 24-year-old age group. Next slide. So I welcome anybody, if anybody can come up with a major category that I don't have on this list, that I separated out between intrinsic and extrinsic factors impacting this trajectory. Okay. Like, how do you end up in that group that requires 24/7 versus that so-called optimal outcome group? How does that happen? Cognitive ability is a big factor. And we deal with cognitive ability when we do an ASD diagnosis as with or without intellectual impairment or with or without intellectual disability. Those that have intellectual disability have more challenges that they face. The autistic symptoms break out into individual clusters. So you can be somebody that's very verbal and wants to be social, but only wants to talk about Star Wars, right? You can have somebody that is verbal but doesn't really like people. And then you could have somebody that's not speaking, so and these factors, and the communication one is maybe the biggest one, but each of these can independently impact outcome. Medical providers, we deal with the medical and mental health issues. We're going to highlight those in a bit. Specific behaviors like spitting or aggression, can get in the way. And then the extrinsic factors that none of us like, but need to look at that elephant in the room, the socioeconomic impact and access to services, the community that you live in, and this concept of case management that we're going to talk about in a second. If we go to the next slide, we'll talk about it. So we did a study. Emily Myers was the lead author. She's a colleague of mine at UW. We had access to this National Longitudinal Transition Study, which was a prospective cohort study, and it followed a group of people with these intensive 30-minute phone calls at 5 different points, starting in early adolescent or early teen years to 20s. Okay, and they were contacted 5 times. These bar graphs on the right are the first wave in the early teen years and the last wave in adulthood. And we were interested in the group of people that had an autism diagnosis, and we were specifically interested in questions related to participating in the community and the social participation. And what do you see about these 2 bar graphs? What we see is social participation stays pretty steady. Maybe that's an intrinsic factor, I don't know. Community participation goes down significantly. And this is across that big bridge that we talk about, loss of services at this age, okay? We looked at variables influencing these, and community participation was influenced by income, okay? That unfortunately doesn't surprise us, and by case manager. Did you have a case manager? And social was also influenced by whether you had a case manager or not. Who's the case manager? Sorry, you guys. It's all you on the call. Just like Amy talks about at the beginning of building your skills. We're sorry that our medical system is such that it puts you in that position to have to take that role. But we see it not just in our individual cases, but we see it in the data that supports that the importance of that case management. If you go to the next slide. All right. Katrina, anything to add to that little section? All right, we'll keep going.
No,
Co-occurring health conditions in autism. Go to the next slide. Health and healthcare outcomes, bad outcomes, right? So I think the take-home message is that something about the autism spectrum brain and living on planet Earth puts you at more risk of developing medical and mental health conditions. And we see them in increased ED visits, hospitalizations, higher healthcare costs. Any way you slice it, you end up seeing it. If you go to the next slide. Most people, if you look at the numbers, most people with autism have something else going on that often and sometimes can even become their biggest barrier, even more of a barrier than the core autism symptoms. A lot of the core autism symptoms are their strengths. Some of them are barriers, but a lot of times these medical and mental health conditions become even more relevant. Next slide. This is just a list of and what you'll notice about this list if you're a mental health provider or know this type of work, a lot of these on this list are on the what we call the affective disorder side. So mood, anxiety, depression. But there's another big one out there, ADHD. So we like to put that at the top because the co-occurrence with ADHD is huge in autism. Some of these other conditions like catatonia and disruptive behavior as a kind of unspecified are also listed and are also increased. Next slide. Oh, and I should put that, I'll comment on that little comment I had at the bottom of that slide. If you look at in the literature, it's been pretty consistent. By the time you're in your AC's age, second half in your late teens, 65 to 80% of people with autism diagnosis are on at least one behavioral psychiatric med. Next slide again, sorry. There are also medical physical conditions that have been identified. One of those kind of a neurological condition of seizures and epilepsy that has increased numbers as high as 20 to 30% in some studies, suggesting people will have a seizure in their life. Sleep conditions, sleep disorders, primary sleep disorders, secondary sleep disorders like poor sleep hygiene or anxiety and stuff like that really further impacts your ability to function in the daytime. And then GI dysfunction, constipation, irritable bowel, reflux, and then feeding issues. Next slide. Supports, when you think about transition, I like to put this slide because when I look at this list of like, what are the things that we prescribe for young adults or in this transition age to help them continue on their track, it's the same list that you think about with little kids. One of the problems is we don't have as many providers and we don't have as many people that are well trained. Insurances don't cover as well. There's lots of barriers to get access. A lot of these services get delivered in public education systems, and that system goes away with their supports. There naturally are a lot of medical treatments that are not well studied and not proven with good evidence. But hey, we get desperate when people are not doing well and we're failing with our recommended treatments, or we can't access our recommended treatments because of those barriers. Next slide. I like to highlight this term and topic, and as a neurologist, it really resonated with me when Dora Raymaker, who's an autistic researcher herself out in Portland State in Oregon, published on cognitive on masking and the specific term about autistic burnout and the brain fatigue that occurs for autistic people trying to fit in schools, trying to fit in home, and trying to fit in the community and the workplace. People that come home and are totally exhausted at the end of the day. I do like to make a comment here, though, that some people choose to mask, and that's their choice and prerogative. And so it's important to educate about the amount of brain energy, and that all humans, the brain does not do a good job of storing energy. And it's not just autism that experiences this. Other central nervous system conditions like multiple sclerosis and traumatic brain injury also get exhausted before the end of the day. And whatever your condition, when your brain gets exhausted, your weakest links become even weaker. So your symptoms, so if you're autistic and your communication is impacted and you get burnout, your communication gets worse. And again, burnout could be day to day, or it could be over weeks to months of getting kind of burned out. Next slide. So, any thoughts, Katrina, before I go? I'm kind of whipping through. Okay, we're good. And I think we've got 4 minutes left. How many slides do I have left? Not that many. I like to throw this quote up. It's an ironic quote, I feel, and a poignant quote with regards to. Oh, I lost. Did I lose my slides, or was that me?
You
We'll
did
work
lose
on
your
it.
slides. Yeah, we might want to pull them back up. Are we?
Yeah, we're working on that behind the
Okay.
Oh,
scenes
no
there.
problem.
Johnny will get him.
All right, good, good. The book Neurotribes is, if you haven't read it, it's a recommended read. Hans Asperger, as you know, Asperger's disorder was one of the first to describe autism. Hans Asperger was a Nazi, and the talk that he made is the first known published lecture on what would be known as autism. Even Hans Asperger could recognize that not everything that steps out of line and thus abnormal is necessary to be inferior. Next slide. So I like this slide because it's an important thing for you case managers out there, you parents and case managers, to recognize that if your medical provider is just focused on health and mental health, it's going to be hard to maximize that quality of life. It's all interconnected. How you do in your employment, and think about this with all of us, right? This is not unique to autistic folks. So it's nice to remember what's our goal. Our goal is maximizing that quality of life in the middle. Next slide. I have to give a lot of credit and shout out to my parent advocates and my self advocates, about moving this field along. I feel like I have moved to where a different place than when I started my practice. And, it's all about being person centered and strength based. And that's the way out of most dilemmas. And it's funny because I'm a big sports fanatic, and I've been listening to a lot of sports talk radio. This is not just our field. This is occurring in sports psychology and business, everywhere. And I feel like we can lead with this concept. So I really want to emphasize that and thank all the families and autistic folks out there that have helped me in getting this better understanding. Next slide. Two questions that I used to ask at panels a lot of times of adult self-advocates was, what would you tell your parents and teachers that they might do differently when you were like a fifth grader, that knowing what you know now? And two things always kept coming out. One is, I wish you'd stop focusing only on the negative. And two is, I wish you would have taught me to self-advocate earlier. And I attach it to this superhero slide just because I like the picture, and I think the characters look pretty cool. Next slide.
Gary,
Yes.
this might be a good time. I just have one comment here about
Yes.
that. So I always think when we talk about, focusing on, using more strength-based approach and positives, so important, right? Because, autism, people with autism, it's not bad. They're not bad, right? But I always kind of draw out when we have this conversation, I like to just draw out that about this presuming competence. Sometimes some of the aspects of autism, not the person, are very negative. It doesn't mean we still can't presume competence and identify those strengths and talk about the problems and challenges and the negative aspects of, of being autistic. I guess what I say now is presume competence, but don't lose sight of reality. Many of us in the profound autism world, presume potential. I guess I want to, it's not like it's always equal. Equal doesn't mean same. And so I get a little sensitive about just, if we just stay focused only on positives, because it kind of shrinks me and people like me being able to talk about the negatives, because there's some negatives. So there's a way to do both. I just wanted to point that out. And
Well,
it's okay to do.
I love that, and I love to push back on it, because I think the point that I'm making here is that your strength is what's going to get you where you want to be, right? And so finding your strengths within all of that, yes, there are all these barriers, right, and all these challenges, but it's going to be the strengths that are often going to pull you out, right? And so that's great. Thank you for that.
Yeah.
We're out of time, and I got about 10 slides left, so I'm going to do this really quick. Okay, so we'll go. This slide is great. We love this slide. A lot of providers have downloaded this slide to give out to families when they make diagnosis. Next slide. The family journey and where you're at as a family is really important, I think, to recognize when you're working with you as yourself or working with somebody. We want to get away from the initial phase where it's just chaos and get to the phase where we can really celebrate the person for who they are. So it is a journey, and it varies in a person how long they go in different phases. Next slide. And we've talked about how sometimes the goals of parents don't align with self-advocates. I think there's more in common than difference, and I think that this slide highlights this. This is from some surveys and questionnaires and interviews that we did with some parents and self-advocates, and you see how similar the goals are on the two sides. Next slide. And when we look at factors, I love this slide, really highlighting the things. These are identified by primarily by autistic self-advocates, of looking at, like, what are the things that are important to me that we need so that we can get that good quality of life, get those mental and physical health supports in place, help me continue to grow reach my social desires. Really important to recognize how much trauma occurs to individuals with autism in their childhood, and to recognize and to be trauma informed in your approach. We'll go to the next slide. Really great to highlight this slide about cultural differences, both in the perspective of what is IDD and autism, so from the parent's perspective from different cultures, and also what those parents might be experiencing that are different if you're not coming from the same culture. Really exploring that cultural identity for that family can be helpful when you tailor your program and when you tailor the supports that are going to help support growing those strengths. Next slide. I'm going to close with this point about employment in adults, that employment is a great example of community participation. And employment can be thought about as competitive employment, supported employment, and you have some individuals with autism that choose or are unable to reach either of those communities, but still want community participation. When you look specifically at employment in really well-designed studies, like the Taylor study that I highlight here, what you see is employment as an example of community participation helps the person continue to make progress. So this is, to me, the key treatment, quote unquote, if you want to use that word and put it medical language on it, is to participate in your community. Next slide. This is just to highlight that point about, I wish you wouldn't always focus on the negative. Is hyperfocus always a bad thing? No, it's not. And these are some examples, and trying to twist those things that are often framed as negative. How can we make this into a positive? Next slide. To me, these are, I spend a lot of space in the employment space right now. And it's really cool looking at both the opinions of employers and autistic employees. And these things are not rocket science. Matching your skills and abilities with the job, getting work experience, focusing on supports in the workplace. So these are things that everyone could benefit from, but people that are autistic and neurodivergent need these supports even more than others often. Next slide. And a shout out to all of those that can't access employment. We need more research in the area of this community participation, because I have been convinced of this doing this work now for over 30 years. And I think the more we can continue to include and to make our world a place that all people can participate and enjoy, I think the better that we all are. So I will stop there. And I went 6 minutes over, Amy. Sorry about that.
That's quite all right. Thank you guys for a great presentation today. We did have some chats come in for questions for you guys. I think people were really engaged in the conversation and had some really big questions for you.